as the chief guest for this very special event, particularly Mpro 2025. This is the first ever national mock practical in radiation oncology conducted in the form of webinar. This is truly a landmark initiative. For the very first time, we are bringing together the clinical case presentation and OSCE discussion in a structured exam-like format, but in a comfort of shape and also in an academic platform. Each day, a resident will present a clinical case, long or short case, while another will take up the OSCE. This session will be guided, critiqued, and also enriched by senior mentors from across the country. This is not just an academic exercise, it's a rehearsal, a confidence building opportunity, a stage where the future of our specialty can practice, learn, and grow before stepping into their final examination. I would like to sincerely acknowledge the vision and dedication of the SCOPE group, particularly the SCOPE. It is simplified, comprehensive oncology practice and education. So not only mine, all the executives of ARI give special thanks to Dr. Kannucharan Patra and also Dr. Ajitesh Avinash, along with the OSCE mentors and their enthusiastic team. All of your passion, selfless effort, and commitment to teaching have made this event possible. This truly embodies the spirit of collaboration and mentorship, which is the backbone of our association, that is Association of Radiation Oncologists of India. To the resident who are the part of this program, I urge you to treat this opportunity with the seriousness of your real exam. You should be very free and frank and also ask the question, interact freely with your mentor, and above all, learn from the processes. Beyond knowledge, this exercise will give you discipline, a confidence, and the ability to think on your feet, qualities that will serve you throughout your careers. As president of ARI, I want to reassure you that the association will always stand behind such innovative academic endeavors. Mpro 2025 is more than just a mock practical. It is a platform that strengthens our fraternity and ensure that our next generation of oncologists will be not only competent, but also compassionate. I once again congratulate the organizers, faculty, and residents for making the pioneering effort a reality. I personally look forward to monitoring the tomorrow's session particularly because I want to see and also interact with all of you. And my special thanks to all the team and also all the participants. Thank you. Thank you once again.
Sir, thank you for your nice words. It will encourage us to continue the process. So we are starting our first case today about the cancer cervix presentation. Will be presented by Dr. Donna Vincent from Mahatma Gandhi Cancer Hospital Research Institute, and will be moderated by Dr. Parthasarathi Bhattacharya. He is very much interested in the treating the cancer cervix, and he is a most enthusiastic in the brachytherapy. So I welcome both. Dr. Donna, please present your share your presentation, and I ask Dr. Bhattacharya to coordinate and mentorship the presentation.
Just 1 minute, we'll be setting up one audio. 1 minute, please.
नहीं हो रहा है क्या? Okay ना? Yes sir. Present.
Good evening all. I am presenting a case on carcinoma cervix.
Not fine.
Am I audible?
You're audible, Dr. Dona. You're audible.
I examined 56-year-old postmenopausal female, resident of Srikakulam, a farmer by occupation, belonging to lower middle socioeconomic status, complaining of
Type not well. Go back.
complaining of whitish discharge per vaginum since 4 months, abdominal pain since 3 months, and bleeding PV since 2 months. As I narrated with the patient was apparently all right 4 months back. Then she developed whitish discharge per vaginal, which was insidious onset, serosanguinous discharge of copious amounts, and she changes 3 clothes per day. It was associated with a foul smell and not associated with itching or fever. Then she developed abdominal pain of 3 months duration, which was onset was insidious over lower abdomen, mild intermittent dull aching pain, no aggravating or relieving factor. Then she developed bleeding per vagina of duration 2 months, which was insidious in onset, streaks of which was minimal in quantity with streaks of blood with whitish discharge and no passage of clothes. There is a loss of appetite present and weight loss of around 5 kg in 2 months. The patient has no history of back pain or flank pain, itching our genital region, burning maturation, blood blood in urine or stools, or altered bowel habits, passage of stools per vaginum, mass coming from vagina, urine leakage, or a swelling of feet or generalized swelling or postcoital bleeding. There is no history of cough, shortness of breath, chest pain, headache, head railing sensation, bony pain, and no history of yellowing of sclera or fullness or a mass in abdomen. Moving into past history, there is no significant past history, no similar complaints in past, no history of chronic disease or medical or surgical history. There is no history of genital warts or STDs or use of oral contraceptive pills or hormone replacement therapy. There is no history of multiple sexual partners. No vaccination. Vaccination history is not known, and there is no history of previous gynecological examination. Moving into menstrual history, she attained menarche at 13 years and with a regular 30 to 32 days interval cycle, lasting for 3 to 4 days. With mild pain and attained menopause at 46 years. Marital history: she was married at 18 years. Her husband is farmer, died 10 years back. No history of multiple sexual partner or STDs in partner. No family planning procedures done for husband. Obstetric history: P4, L4, 2 girls and 2 boys, delivered by a normal vaginal delivery at hospital. First childbirth at 19 years. All 4 children were breastfed and no contraceptives used. Tubal ligation was done after last childbirth. Moving into personal history, patient takes mixed diet and she has decreased appetite. Bowel and bladder habits are normal. Sleep is adequate. No history of smoking or alcohol use. No drug or any food allergies. There is no similar complaints in the family or no significant cancer history runs in family. Moving into general examination, patient was after informing the procedure of the patient, explaining the procedure, patient was examined in a well-lit room. Patient is conscious or cooperative, well-oriented to time, person and place, with a performance status of ECOG 1, pain score 2. She is moderately built lady with weight of 60 kg and height of 157 centimeter, BSI is 1.6 meter square. Patient is febrile with normal vitals, BP 120/80, pulse rate 72 per minute, and respiratory rate of 16 per minute. Pallor is present, bilateral pitting edema below the knee present. No ulcer or varicose vein is visible over legs. No icterus, cyanosis, clubbing, generalized lymphadenopathy, or skeletal tenderness can be witnessed. Moving into systemic examination, central nervous system, higher mental functions were normal, speech and memory was normal. Respiratory system, patient was sitting comfortably with thoracoabdominal respiration with symmetrical movement of chest and no dilated veins. On auscultation, bilateral air entry equal bilateral air entry and no hearted sounds heard. Cardiovascular system, on auscultation, S1, S2 heard, no murmur, no abnormal sounds heard. Per abdominal examination on inspection, abdomen is flat with a regular respiratory movement. Umbilicus is centrally placed and inverted. Multiple stretch marks with tubectomy scar was present. No dilated veins or fullness seen over abdomen or flanks. On palpation, all the findings of inspections were confirmed. Per abdomen was soft, non-tender, no guarding or rigidity, no organomegaly, no tenderness over flank, and no inguinal nodes palpable. And on percussion, there was no evidence of ascites. On auscultation, bowel sounds were heard at regular frequency, 2 to 3 sounds per minute. For local pelvic examination, patient was kept in lithotomy position. On inspection, external genitalia, the bones pubis, labia majora, minora, clitoris, urethral opening, suburethra, and anal verge seems to be normal with normal pubic hair distribution. Whitish discharge was present over introitus with foul smell and soiled underwear. On cuffing, no prolapse was seen. No smell of or leakage of urine or feces seen. Per speculum examination using self-retained speculum, a 4 cross 3 centimeter ultraproliferative growth was seen over cervix, involving both lips and all fornices. Cervix is not seen separately from the growth. External os is not visible. The lesion was extending to upper 2/3 of vagina posteriorly and upper 1/3 anteriorly and laterally. Per vaginal examination, per speculum findings were confirmed. No growth was felt over mons pubis, labia majora, minora, clitoris, urethral opening or suburethra. Vaginal length was of 7 centimeter. Firm ultraproliferative growth, viable mass of size 5 cross 4 centimeter was palpated over cervix, all fornices and vagina. Vagina upper 1/3 was involved anteriorly and laterally, and upper 2/3 was involved posteriorly. The lesion bleeds on touch, and there was no abnormal communication felt between vagina, was felt in vagina. In bigenital palpation, index finger was kept in vagina and middle finger rectally. Sphincter tone was normal. Anterior rectal mucosa is smooth. And parametrium was palpated proximally in the left side and over the right side till pelvic side wall. From all the examination, the tumor size was of approximately 8 centimeter in width, 4 centimeter in length, and height of approximately 5 centimeter. No pouch of Douglas deposit was felt, and no abnormal communication felt between rectal mucosa and vagina. A summary: 56-year-old postmenopausal woman with no comorbidities and significant past history, complaining of foul-smelling whitish discharge and bleeding PV with significant weight loss, pallor, and pedal edema. On examination, ultraproliferative lesion of approximately 8 cross 4 cross 4 centimeter over cervix, involving both lips and all fornices, and upper 2/3 of vagina involvement. Bilateral parameter was involved, right side up to pelvic side wall and left side proximal involvement, which bleeds on touch.
So nicely presented history, Dr. Dona. So from this, you should have something in mind. So what are the diagnoses that are coming in mind?
Since it was a short history of 4 months, and the lesion can be seen, ultraproliferative lesion was seen over cervix involving fornices and parametrium. Also, it bleeds on touch. So my professional diagnosis is malignant lesion of over cervix.
So apart from that, what are the positive history you can substantiate from this diagnosis?
So she was complaining of whitish discharge, bleeding PV, and weight loss was there around 5 kg with pedal edema and pallor. Also, mass was palpable. Gross mass was palpable.
Suppose if I am asking you, did you examine what was the did you check for pallor anything?
Yes, pallor over lower conjunctiva was same, sir. Pallor was less.
And what about general lymphadenopathy? Did you check anything?
Checked for whole supraclavicular, there was no mass, axilla, inguinals, parabdomen, and popliteal was checked, sir. There was no mass.
So you think of it as a CS cervix?
Yes, sir.
Maybe some malignant lesion of the cervix that we all agree. But what are the nodes that you are likely to check in this patient? Because in the mid of the examination, while you're discussing with the patient, some diagnosis automatically comes to the mind. So based on that, what lymph nodes or what are the groups of lymph nodes in this patient you're likely to check?
First, I would like to see for parabdominal. You see for any parayotic, any abdominal parayotic fullness or
No, I mean periodic lymph node palpation is a very difficult one. Come to the easier versions first.
inguinals will be checked, sir. Then supraclavicular should be checked.
Okay. So periodic can palpated only when the
Yes.
lady is very thin. Huh? And it is very difficult to palpate in a 60 kg old lady, 60 years. What is the age of this patient?
56.
56 is the age,
60 kg.
weight of 60
60
kg.
kg.
It will be difficult in this lady. So apart from this, the cervix malignancy can be one of the first thing that comes to mind. Any other things that comes to mind if someone asks you on the differential diagnosis, if you can put one or two into parameters, but we all agree that it can be a cervix, but one or two maybe in the back of the mind other than that.
Yeah, endometrium extending to cervix.
C endometrium extending to the cervix. Very likely, unlikely scenario in this. Any other?
Pelvic inflammatory disease. Yeah.
Maybe infected ward condylomas can produce such type of lesion, but very unlikely. But you can have those such of scenarios also. Okay. So based on this, we have come to the differential diagnosis also. So what other things you will do next to the patient to conclude your diagnosis?
So, first, I will do the basic investigations like CBC before the diagnostic testing. I'll do CBC, LFT, creatinine, the serum markers, HIV, HbSAg, or HCV. Serum markers will be done prior to the bio. Then after that, I would like to go for biopsy from the lesions.
So what are the different types of biopsies that we do for a CS cervix patient? Many centers, the radiation oncologist, when we are students, used to do the biopsy. So nowadays, of course, in different centers, you'll be referring to other places, gynecologist. But as a radiation oncology student and also a clinical oncologist, you should know what are the different types of biopsies that can be done in this.
So in cervix, punch biopsy should be taken. Also, we should take multiple biopsies should be taken from the lesion. Also, we should avoid necrotic area for the biopsies. And other types of biopsies are edge biopsy, wedge biopsy can be done. Core needle biopsy, excisional, not for cervix, but other types of incisional biopsy, excisional biopsy.
So what are the area, which area you will select for the biopsy? Suppose you are seeing a lesion in the cervical lips. So which part of the lesion will go for the biopsy?
Posterior cervical lips will go, sir. Also, we'll take first we'll take some posterior lip. Then again, we'll take multiple biopsies.
So I mean, you are seeing a lesion which is centrally located, involving both the cervix lip and going to the fornices. So which part of this you will hit for the biopsy?
Fornices I will take more. Centrally, there's chance of necrosis, sir. So we'll go for the peripheral areas.
So it is some amount of normal tissue and some amount of abnormal tissue should be there in the biopsy specimen. And always you should exclude the areas where there are necrotic deposits or necrotic discharges from the patient. Okay, you should never try to do a biopsy if there is an impending fistula from that area. Okay, you should be very careful because you should not make a partial fistula, total fistula. So these things should be remembered while taking a biopsy. So what are the things coming to the examination of the patient, local examination? So what are the things you will try to see in a parvaginal and parrectal examination?
So in pervaginal exam, first I will feel for the perineal regions, whether any lesion of mons pubis or labia majora minora, any interaction of urethra, suburethral area. Then how the introitus is. Then I will do, first I will palpate all these regions. Then I will gently insert my fingers into vagina and see for how the lesion is, whether it's ulcerative growth, proliferative growth, bleeding is there or not. Then I will go for the extent of the disease, extent of whether the lesion is involved in the whole cervix, the fornices are involved, or the vagina, the extent of vagina, whether the upper two-third or lower one-third is involved or not. Then this is for per vaginally I will do. Then for
So we'll go step by step. So before putting the speculum, per PV examination also include inspection of the, as you told, the inspection of the vulva, the forceps, the introitus, the urethra, urethral opening, and the suburethral region. So it is very important some in cases where there is infiltrative growth. So in cases of infiltrative growth, you do not see much in the cervix, but we can see something under the vaginal anterior vaginal mucosa involving the suburethral. So suburethral examination becomes a very important component in per vaginal PV examination. Okay. So in the PV examination, after the inspection with the speculum, you are supposed to see the entire vaginal canal. Okay, from the top to the introitus, all the circumferential. And as mentioned in the Jackie Stroh that clinical diagram paper, you should write down or note down where the lesions are there in the vaginal canal, also in the cervix. Okay, you should always follow that paper. Now, coming to that, what additional information you get from of the parametrium from a PV examination? The question is, how can you comment about the parametrial involvement in a paravaginal examination?
Nodularity.
mobility, if the most mobility is
If you are unable to answer, I'll open it up for the other candidates. Okay. I'm talking about, suppose you are doing a PV examination. I'm not talking about a PR examination. I'm talking about a PV examination. And in the PV examination, can you comment on the parametrium?
Yes, sir. Nodular parameter. The paracervical
Any
node
other?
involvement.
Anyone wants to comment on this? Any other student?
By examination have to be
Someone can interact if possible, because seeing the message will be difficult for me.
Nodular parametrium, so paracervical node involvement can be assessed.
Anyone?
only by digital
Hello?
examination we are able to check the NMD and then we'll get to know how much parameter is in it.
Examining by PV examinations, but we don't know the entire extent of the parameter involvement or not.
So sometimes the scenario becomes very difficult. If the entire cervix and the upper third of the vagina is involved, it's very difficult to give a comment on the parameter. But if only the cervix is there, you can put, and the fornices are very deep. In such cases, in few cases, you can put the finger in the parametrium, in the fornices, and find out something about the parameter. Invasion is there or not, but it is not the conclusive finding. Okay, so some type of invasion to the para can be commented by PV examination. As we told, PV and PR gives a complete examination. Without both this examination, you are not supposed to give a partial information in the case sheet. Okay, so as I told you, now you are well aware. All the students should be well aware about the maximum depth their fingers can stretch up to. The middle finger and the index finger, this should be able to stretch for certain centimeters. Everyone should have the measurement. So majority of us will have 5 to 6 centimeters stretch from the tip to the tip of these both fingers. Okay, this gives a approximate scale when you put inside the vaginal canal, because there is no way to measure, put a scale inside, is it not? So it gives approximate about 5 to 6 or 4 to 5 centimeters depending on the finger width. So you can know the extent of the lesion from this measurement of your fingers. Okay, so that is one information. Also, it is very important to note down sometimes there are subclinical involvement of the urethra or suburethral region. So in that case, the treatment definitely differs mostly in the brachytherapy. So if there is suburethral involvement. Now coming to the next part of the examination. So what is done next after PV examination?
Biomanual calculation is done.
So what information you tell a bit louder because the audios might not be clear. So bimanual. So what information you can get from that?
I first so the tone of anal tone was sphincter tone was analyzed first.
Analysis of the sphincter tone is not my primary concern.
digital.
So whatever is not my primary concern should be at the second or third option. First option should be about the disease.
Then parametric involvement can be assessed with rectal examination.
Before that.
Before that, rectal mucosa involvement.
Before that.
Anterior rectal mucosa.
So you are putting your index finger and the
proximity of the vaginal and rectal mucosa can be seen. So whether the rectal mucosa.
First of all, you should see the rectovaginal septum. Okay. So any extension of growth into the rectovaginal septum can be easily felt by these two fingers placed anteroposteriorly. One finger inside the vaginal canal, one finger inside the rectum. So different students will have different length of fingers, but usually it will give a gross idea about the status of the patient. Okay. So the next thing, what you are supposed to do?
Parametric, we'll see the extent of parametric involvement. So in this case, it was right side, it was involved in pelvic sideboard, and left side it was only.
So how do you tell it is the right side para is involved with the pelvic? What findings tell
Actually,
you?
in the bone and this, there was no space, and also there was no mobility of the parametrium was.
So first of all, you should place the finger in the central part of the cervix or the okay, from the rectum, and then move laterally from right to left or left to right. Okay, you should not do both together. So we start from the center of the cervix and move to the laterally to the pelvic wall. Now in this maneuver, we try to see the any nodularity is there or not. Any pain, any shortening of the parametrium, any fibrosis of the parametrium is there or not, any tenderness is there or not. You try to feel the uterus also, whether the uterus is extremely retrograde or not. You can feel it. Okay. So sometimes we do not feel the uterus. In such cases, we can do a bimanual examination, putting another hand on the lower part of the suprapubic area of the abdomen and pressing down on the uterus and checking the mobility or the position of the uterus. So that position of the uterus becomes important in certain scenarios. We'll tell later. Yeah. So parametrium rule out by nodularity, fibrosis, fixity, and no movement of the cervix and the uterus. So if that is there, almost always the parametrium is included. So do you think the clinical examination is sufficient? Or some other investigation also needs to be done to rule out parametrium?
MRI pelvis should be done to rule out parameter involvement, but a good clinical examination can be done. So if it
is almost always equal to the MRI findings. So if a good clinical examination of the parametrium is almost equal to the MRI findings. What is that? Put it off. So we have come to the examination of the parameter. Okay. During the examination of parametrium, also you should feel for the rectal mucosa. Okay. So anterior rectal mucosa is okay, or some amount of fixity is there or not. Huh? Or if you find some indentation in the rectal mucosa, induration in the rectal mucosa, anterior rectal mucosa, you should examine it properly to rule out any rectal infiltration. Okay. Another point of concern is to the students, especially when there is a rectal infiltration. A partial rectal infiltration should not be made into a complete rectal infiltration with the help of your peer examination. So that should be you should very carefully do this part of the investigation. Otherwise, patient will become a 3B patient might become 4A. Okay, so that part should be very significant during your maneuvers. Okay. Okay. So here you told about checking the anal tone also. So what is the significance of checking anal tone? Why it is important and why it should be lost?
Sphincter involvement, so if lower third of vagina is involved and the sphincter involvement is.
So many scenarios can happen like that. Okay, the patient might be a case of rectal prolapse. It can be a loss of anal tone. It can be extensive involvement of the levators going up to the reaching up to the lower part of the anal canal. It can be different scenarios, but that is also an important things to consider. Now, another thing you didn't tell us, what is the length of the vagina? So 7 centimeters was the length of the vagina. You should be able to know the anatomy of the vagina by this time. How much of the length of the vagina is involved and how much is spared, and why it is why it is important to differentiate between upper 2/3 and lower 1/3. Anyone can come in to answer if you are willing. We need an active participation. Yeah.
So the upper two-third of vagina is embryologically different, sir, from the lower two-third. So
That we understand, but what it is different, what ultimately clinically how it is different.
staging is different, sir.
Hmm.
If
Sympathetic
upper one-third,
drainage is
upper two-third
different.
is involved, it is 2A. If lower one-third is involved,
Upper 2/3 is involved, it is 2A. Okay.
lower third is involved, it will be 3A.
Yeah. And any change in the lymphatic distribution?
If lower third is involved, there is a high chance of it is supplied by inguinal region, lymphatic. So there is chance of lymph node possibility in inguinals also. So during treatment, we should treat inguinals also. Lower third.
Okay, fine. So what is the size of the lesion according to you in this patient?
8 crores, 4 crores, 5 centimeters.
So 8 is what?
8 is the width, sir, with parametrium. 4 is the anterior posterior length, and 5 is height, sir, which upper extent I wasn't able to. It was approximate dimensions, sir, height.
Okay, so upper extent it is very difficult to unless you go in have a endometrial or a myometrial investigation like MRI and others to see the uterus involvement or involvement of the it's very difficult to tell the upper extent of the disease with simple digital examination. So that one is always an approximate, but other two dimensions are always almost final. Okay. So based on this, it is a case of 3B service. 3B service. So you have done an biopsy, or maybe a punch biopsy you have done, and all the serum chemistries came out to be normal with a hemoglobin of 8. And what next you want to do in this patient?
Sir, we're staged it accordingly. So the staging diagnosis we can see, sir. Since it's a already stage 3 pelvic circles involved, we have to see for any creatinine is raised, any H1 is there or not. We can, even though if it,
Yeah, I told you everything is fine except hemoglobin is 8.
Hemoglobin 8, then we should do blood transfusion, sir, because at least 10 should be the hemoglobin before starting the treatment.
And why it is 10 is so important?
So in studies, they have shown that the treatment response was good with hemoglobin more than 10 to 11 more than.
So in Indian scenarios, we are
Poor prognostic factor.
always anemic. So 10 is the baseline hemoglobin that we should maintain. And in different studies, it is seen the sensitivity of the effect of radiation and chemotherapy is always good when the hemoglobin is the cutoff of 10. Okay, so 10 isn't. Now you told about creatinine. So creatinine, how creatinine is important in such patients?
So in the
Involvement of
special already
compressive
three. So in staging, creatinine is involved in staging purposes, sir. If stage 3B is if 3 points are there, if pelvic sidewall involvement, H1 or any non-functional kidney is there, then it will be stage 3, sir.
No, you didn't get my question. I told what is the importance of creatinine in this patient?
Sir, in this way, we'll be given chemo for this patient, sir, cisplatin. So in that renal function should be good.
So that can be assessed by a creatinine. Okay. So fine. You got an punch biopsy. You got your serum chemistries. What other investigations?
Since it's 3B, I would like to do cystoscopy and sigmoidoscopy for this patient. So any mucosa involved.
Any other radiological investigation?
MRI, T2 MRI pelvis.
So what information you want to gather from there?
That will see the parameter involvement can be seen and how the lesion parameter involvement, the size of the lesion, the no.
So you are doing a T2 MRI. So you in your previous few minutes where we discussed almost the right to left dimension of the tumor and the anterior-posterior dimension of the tumor is almost clinically ascertained. So what additional dimension you want to get? Okay. So superior extent of the tumor, whether the tumor is invading into the uterus, myometrium, and what is the upper extent of the lesion can be found out from it. Okay. So in biopsy, what are the two common histopathologies that comes in such patients?
So for cervix, it's usually
Squamous
squamous cell
and
carcinoma or adeno can be with
You do not tell like that. You tell by percentage.
squamous cell carcinoma around 90%.
So nowadays it is shifted to up to 85%, if I am not wrong. Okay. So 85% of the cases under the different types of squamous cell carcinomas and 15%, 10 to 15% of the cases of adenocarcinomas. Okay. Okay, fine. So after MRI, what other investigation you want to do? You told about cystoscopy and sigmoidoscopy. Why you want to do that?
So, since it's if you see any mucosal environment, this bladder mucosa, rectal mucosa environment, sir, we have to make sure. And
so, in which stages or in which cases of categories of patient you are supposed to do a cystoscopy and sigmoidoscopy?
stage 3, we can go for stage. Can go barrel should be so growth is there. Barrel should grow. We can go for cystoscopy.
Even if it is an early stage, maybe 1B case, if it is a barrel shaped cervix, FIGO suggests us to do a cystoscopy and proctosigmoidoscopy. Okay, fine. So we have come to almost the end of staging. Now, what other investigations you want to do for the staging? The basic investigations. We didn't do quite a thing.
For metastatic workup, we can do for HRCT, chest X-ray or
you didn't do any CT scan of the abdomen or anything others you want to do?
CT scan abdomen can be done, sir, or
Is the CT plain CT?
a CCT abdomen will be done, sir, to see the nodes, involvement of nodes, or PET CT can also be done since its sensitivity.
So which one you suggest?
So PET CT will say about the sensitivity. Say PET CT
if the patient is affordable, which one you suggest?
Patient, I will go for PET CT, sir.
And why? What additional information?
Actually, if lymph nodes are there, if it's sensitivity of and specificity of PET CT is more, sir.
What type of lymph nodes? Which area lymph nodes?
Parietic lymph nodes.
So suppose you should know the sensitivity and specificity of PET CT is much higher in case of only parietic nodes. So if you suspect any parietic node, but you are unable to tell with the conclusive finding in a CT scan, maybe a 6 millimeter, 7 millimeter, 8 millimeter, something below 1 centimeter, that this parietic node is involved, then we can go ahead for PET CT to give us an additional information over and above the CECT. Okay, so what it helps is if suppose a small node is there, which is radiologically not suggestive of metastasis, the PET CT can vary with high sensitivity and specificity can tell in only in parietic cases it is having a metastasis. PET CT is not useful for any pelvic lymph nodes assessment with PET CT. Okay, that one it should be clear. Okay, fine. So can you tell me rule of 15?
Yes, sir. For involvement of parietic nodal involvement, stage wise, we'll say, sir. It is stage.
Bhargav, anyone can answer, please. Yeah.
lymph node involvement in stage 1.
Stage 1, it will be 5%.
15. It goes in 15.
15,
15 into 1, 15 into 2, 15 into 3. That is a hint.
30% stage 3, 45 and stage 4 more than.
No, it's stage 4, no one has told us. The paper by Apila Dushanatham didn't tell us stage 4. It is 15% for the early stages. Mid stage 2, it is about 30%. And anything more than third stage, it is
pelvic
40%.
lymph node.
Okay. It gives it's not a blanket rule. It's not a rule that you should always be true only, but sometimes it gives us a useful hint. This type of patient, maybe this patient may harbor a periodic disease. Okay, so it's a 3B. So we have about 40 to 45% chance of harboring a periodic nodal mass. Okay. So okay, fine. So what are the radiation volumes you want to treat in this patient, or what should be the primary approach for this patient? As a radiation oncologist, what treatment do you advise in a MDT?
Since it's stage 3B disease locally, I would like to go for a radical CTRT, that is 45 to 50 gray closely to the pelvic region. If there's any nodes are there, I will boost up to 55 to 60 gray. I would like to boost up to 55 to 60 gray with the concurrent cisplatin 40 mg per meter square, and EBRT will be given 40 mg per meter square, and EBRT will be given for 25 to 28 days, sir. And over
25 to
28 days.
What should be the total duration of treatment?
It should be given within the recent update says that it should be treated within 42 days or 7 weeks. So it's better to go for 45 grain, 25 fractions, EBRT, followed by it's brachytherapy. So if ICRT or
No, I didn't ask you about brachytherapy. So there should be the standard. You should try to finish everything within
42 days, 7 weeks.
7 weeks time. Okay. So you told 50, 40 and 28 fractions. So this should be, you are extending the duration of external beam radiation, thereby reducing the amount of time remaining for brachytherapy. So nowadays the standard is to give a whole pelvis or a whole paraortic if required up to 45 days. And also if a node is there, to boost it simultaneously along with IMRT. If it is available, the system is available with you, you can always give a simultaneous integrated boost
to the nodes up
to the nodes.
55 to 58.
55 to 58 grades, all finished to be finished within 5 weeks time in 25 fractions. So the patient has about approximately 2 weeks time to complete the brachytherapy. Okay. So there should be the standard. You should not tell 50, 40 in 28 fraction. Okay. Now I'll go to now you people are all 3D people. So you have done all your planning in 3 dimension, I hope. So I'll not discuss 3D at this point. Maybe in the later part of this we'll discuss. So tell me about the 2D borders of CSLs.
If only pelvic nodes are there, we'll in AP. In AP, the superior will be L4, L5 border. Inferiorly, obturator foramen or
L4, L5. You tend to differ here.
Then that is according to the involvement of paratic nodes. If my paratic nodes, if minimum of 3 pelvic nodes are involved, I will include the paratic.
I'm telling only pelvis. Paratic will go next step. L5 as well is very low.
L4,
Mid of L4.
L4,
L5.
superiorly L4, L5. That should include the common iliac nodes.
So usually 2D planning doesn't mean you are doing entirely everything in 2D. You do not have any information of CT scan. You are doing a diagnostic CT. So you know the lower border of the bifurcation of the aorta into common iliac. So that area sometimes it bifurcates in L3, L4 also. So that area of bifurcation from the CT scan information you should come to the 2D or a simulator plan and take accordingly. So it can be L3, L4 or L4, L5, depending on the number. Hardly it is, many of time it is in the L3, L4 region, okay? Upper part of the lesion. So that is the upper border. What is the lower border?
Lower border will be obturator for lower border of obturator foramen or 2 centimeter from the lesion. Which one is more? That we'll take that as the lower borders.
Tell me about this case.
In this case, it's upper tooth is involved, so I will take 2 centimeter from the lower border. I will put a marker in the lower border, then I will take 2 centimeter.
Ischial tuberosity, you should hit for it. So the lesion should, if it is crossing the ischial tuberosity, you should give another margin of 2 centimeters. The lower border should be always on the simulator film of ischial tuberosity. Okay. Okay. There's some amount of margin of minimum of 3 centimeters in a 2D plan from the lower border of the lesion. You can put some markers with the cotton or a gauze piece in the lower border and take it radiographically. What is the lateral border in AP?
From the pelvic wing should be 1.5 to 2 centimeter lateral to the pelvic wings.
Then why it is 1.5 and 2 centimeters, not 4 centimeters?
To cover actually if we do 4 centimeter, it will radiate more of the pelvic bones. So
it is not about what it's a
nodal.
There is no OIR, suppose. So you'll go 4 centimeters?
No.
Then why
You
you
have
not?
to cover the inguinal nodes, so for that 1 to 2 centimeters enough to cover the.
There is no lower third involvement, then why you need to cover?
Pelvic nodes, sir. Pelvic nodes, to cover the pelvic nodes, it can be covered with 1 to
So
2
pelvic
centimeter.
nodes lies along the pelvic vessels. So what vessels you are trying to see?
Here commonly external, internal, 3 vessels essentially.
And what is the lateral extent of this vessel? How do you clinically mark these vessels in a 2D? Or how do you know this is my lateral border for sufficient for this patient? I am not talking about blanketly giving 15 centimeters or 16 centimeters. You have to palpate the femoral pulses. The femoral pulses and is almost in line with the external iliac arteries. So you know my external iliac artery limit is here. Okay. So that can be the point of the lateral border. So 1.5 to 2 centimeter is roughly coming to that only. Okay. So based on that only, they made this border as 1.5 to 2 centimeters. Though 1.5 we never make, we always make it 2 centimeters only on the higher side, because we should not miss on this any nodes. Okay. Now coming to, you have told us, now here in the AP, you can try to shield off some part of the femoral head if it is irradiated. Okay. But that is a very difficult scenario. But if it is possible, just always try to shield off the head. Okay. With some corner blocks, as almost all of you are following. So upper 2 corners and the lower 2 corners can be blocked off if the immunals are not there. Now, if you go to the lateral, in the lateral border, what is the anterior and posterior border? Upper border, lower border remains the same. What is the anterior and posterior in the lateral border?
With the anterior border of pubic symphysis actually, and posterior it should cover the whole sacrum. And
why the whole sacrum should be? Because
so
as far as I remember, when we studied, they told us not to include the entire sacrum. They told us to by
presacral region should be covered, not should be covered.
Any other answers?
S2 S3 interface. What is the S2 S3?
So S2 S3 was taught for us, but not to make the
Sacral fallow has to be included.
Yeah, definitely. So what are the ligaments that are getting attached to it?
Uterosacral ligaments are attached. So we should cover.
Those gets attached to the sacrums. Okay. So that is the concept of taking the anterior sacral nowadays. Okay. So and also you see sometimes the uterus, the fundus of the uterus, if it is retroverted, tends to go beyond that in the S2 S3. Many of the time in this era of CVCTs, we tend to see the fundus going. If you are giving the border at S2 S3, the fundus is crossing over the border. So it's almost not any. So that is the concept of giving the whole sacrum. So, okay. Now, cisplatin, as you told us. So, who told us to give cisplatin, not paclitaxel or doxorubicin or maybe capecitabine? But why cisplatin only?
It's saying cisplatin. Most of the trials have taken from when taken with cisplatin only, saying green meta-analysis. They are saying that we are getting overall benefit of 66.5% in cervix.
6 to 6.5 overall benefit, and as the stage increases, the benefit reduces. So it is a from 3% to 7% benefit is there. The lower the stages, better the benefit. Starting from stage 1, is it not? So higher stages, the benefit becomes about 3%. Okay. So you should remember this. Okay, fine. That is okay. Now, if you want to go to brachytherapy after the completion of axial beam RT, suppose the patient has successfully completed DBRT and chemotherapy of 5 cycles, weekly 5 cycles, or weekly 1 cycle of 5 cycles with minimal toxicity. One more question is, what are the toxicities you expect during this chemoradiation?
The most common will be GI toxicities. Patient will be presenting with vomiting, diarrhea, mostly diarrhea,
Right.
vomiting or abdominal pain can be researched. Then local mucous skin toxicity can be there, mucositis can be there.
Then how do you try to reduce these toxicities?
So we have to take care of the bowel doses. Also,
In 2D, you cannot take care of the
No.
bowel doses. That is only possible in the era of 3D and IMF. Okay.
Ladder filling.
Okay.
so,
Anything else? Someone was telling something. Yeah. He was telling something. He gave you a hint.
as a full bladder, we can treat the patient or bladder whatever.
So the intestine gets pulled up when you increase the size of the urinary bladder. And also you get a full bladder, empty bladder scan to see the ITV or whatever movement of the uterus it is going on inside. Right? That is all. So before keeping the patient for brachytherapy and to select the procedure, which technique of brachytherapy, what things you need to consider?
First, I will see the initial
extent.
extent of the disease. So then also the pre-BRT extent of disease will be compared. Sir. First, if if lower third is involved, lower extension or lower vagina is involved, I will go for IBT only or interstitial brachytherapy, ISBT.
Tell us the indication of IBT later. We'll deal with the ICRT first.
If the initial disease, if there is no residual disease in the cervix, and if the lesion has responded well to the tumor,
In which cases, in other words, you will do only ICRT.
the initial stage 2 or 3.
I'm talking about post EBRT. Which of the candidates only ICRT?
So according to Mpro, they have divided according to state 1,
Groups.
2, 3, and 4 groups are divided.
So
So in
stage
the, one will go for brachytherapy only. Second, according to scenario, we will take for ICRT or IBT. Sir. 3 and 4 will be taken for IBT. Interstitial brachytherapy.
Okay, fine. So what are the applicators? Can you tell me one or two applicators of ICRT that you are using?
In my institution, we are using Rotterdam, Fletcher Sir. And other can be these are the two which we are using here.
Maybe one or two more.
Vienna, it's a hybrid, sir. Both interstitial.
The ring applicator you can tell. You can tell the Hensky applicator. Okay. So you should always remember what applicators you are using and what are available in the market. Maybe one or two extra. Okay. So you are doing that. So okay. So you during brachytherapy, suppose you have all the options available with you. Will you do a 3D brachytherapy or a 2D brachytherapy? Or a CT based planning or a non-CT based planning?
CT based planning,
CT or MR based planning is
MR
ideally to be utilized. If not, the conventional brachytherapy simulator plan can also be accepted.
Rectal.
So during your prescription, you are prescribing to the point A or you are prescribing to some other points? Or what are the other options of prescribing?
So we are prescribing the dose to the volumes, volumetric prescription we are giving, the HRCT according to the Jackie's.
Suppose someone is not having that option, then what should be his prescription?
The 2D it will be according to point A, sir.
I can do 3D also, still I can prescribe.
Point A, sir. Point A can be given.
So what are the disadvantages of prescribing to point A?
So point A actually it's according to the applicator, sir. So if the if the patient is having low-lying os or the patient is having fornixes, that point A is variable. So we can't rely on point A, sir. So
it's not a fixed point.
It's fixed.
It's a changing point. Okay, so that is one of the disadvantages. Sometimes point A can fall inside some intestine also. Sometimes it can fall into the lateral part of the bladder also. So it is not an ideal point to describe, but still it has been used for long, 70 years, 80 years. It has been used. It should not be easily discarded. We should always note down the dose to the point. What is the other option available to a prescription? Suppose you have MR, you have a
HRC, most volumetric prescription to HRC.
what is GTV in MR? At brachytherapy.
At brachytherapy, the HRC, there are 3 volumes.
I told asked you about GTV.
Brachytherapy GTV will be the residual disease, so whatever it will be the residual disease.
What scan sequence you want to take for that?
So the T2 MRI should be done, sir. In that, whatever the residual is, that will be
How it shows?
in T2, it will be hyper intense in T2.
Anything else? Anything
And
like
the gray zone should also be involved.
what is gray zone?
Gray zone is area where it appears gray. We can't say that.
Doesn't appear gray.
No, sir, we can't. We won't be able to see it, sir. But differentiate whether it's actually
Pure,
lesion or
not
not.
pure. It
Yeah,
AVD.
yes.
So this term was very applicable when the low Tesla MRI was used. Maybe 0.25 Tesla was used those days. Gray zone was much utilized. Now, as the Tesla is increasing, the gray zones also reducing, but still it is significantly there. So anywhere you see, wherever you are having any doubt, keep this disease, it may be a T2 hyperintense area, might be harboring a disease. That area should always be my GT. And what is HRCTV?
HRCTV should include the residual disease plus the cervix, according to Jekyll's.
So entire cervix plus
the GTV, residual disease.
residual disease. Whatever you have drawn in the GTV, that should be the gray zones, everything plus GTV should be your HRCTV. Now coming to the next volume, what is IRCTV?
IRCTV, according to ABS guidelines, we can give differential margin also.
ABS?
Jekyll's guidelines, we can give differential margin to the residual disease. Also, it can be 2, sir. Even the initial volume can be taken as IRCTV, the initial extent of the disease, or the HRCTV plus 1.5 centimeter superior inferiorly, 0.5 centimeter anterior posteriorly, and 1 centimeter laterally.
So 0.5 centimeter anteroposteriorly, cutting off the bladder, rectum, intestine, everything. So 10 millimeters to 15 millimeters, depending on the spread of directions. Okay, and the NE should always include the initial volume of the disease. Okay, if the disease has not responded, the IRCTV volume becomes bigger than the present volume. Okay, fine. So what should be then IRCTV? If the disease was initially only in the cervix, and at present there is no disease seen on MRI, or there is, in other words, complete response after.
It will include the initial whatever disease that
I told you, I am telling you again. What is the IRCTV? If there is the initial extent, initial disease was only limited to the cervix, one lip, and after EBRT there is no, or in other words, there is complete response after EBRT.
To the HRCTV, I'll give the initial margins superior inferiorly 1.5 centimeter, laterally 1 centimeter, and anterior posteriorly 0.5 centimeter will be given with the cervix.
Oh, fine, got it. Okay, so that is why IRCTV. Now, I think we have 10 minutes more. So, what is in which cases you will go for interstitial brachytherapy?
If the lower third of vagina was involved initially, or extensive, if the residual is more irregular geometry of the tumor, sir. If the pelvic side wall was involved, if parameter residual is there.
So extensive disease at present. So anything more than 1/3, crossing 1/3, according to the definitions. Then suppose your upper 2/3, lower 1/3 of the vagina is involved. The geometry is not good. You are not able to do a good implant of ICRT or good ICRT application. In such cases, you can go for interstitial brachytherapy. Can you name some applicants for interstitial brachytherapy?
Martinez universal perineal interstitial brachytherapy.
That is a very old one, yes.
Then where
Any other old?
Midblade is there. Vienna, Venezia is there, sir, interstitial.
What is Vienna?
Vienna is hybrid applicator. It have a ring applicator with the paracervical and paracervical needles and parametric to parametric needles are also there, sir.
Okay, so we have applicators with the interstitial needles in the ring, in the ovoid, with different names, and the latest is the Venezia, which is
Interstitial interstitial needles hybrid can be interstitial needles can be
interstitial needles can be done, and with the vaginal sling, you can treat the lower third of the vagina also. Different modifications, adaptations can be done. This form of application.
आती हूँ मैं थोड़ी देर में, ये 9 बजे तक चलेगा ना, रुकूंगी मैं 9 बजे तक.
Hello?
Please go ahead. Something background message. Please go ahead.
Okay, fine. So these are the ways we can select. So different brachytherapy systems or different brachytherapy planning softwares has different ways of prescribing the dose. Okay? We can do it manually also, not manual loading, but dual point optimization can be done manually. Computerized thing, but the points can be put manually. Another is computerized, where the system does everything for you. So what is IPSA?
Inverse planning.
Bolo?
Inverse planning with simulatory annealing.
Louder.
Inverse planning with simulatory annealing, sir.
Inverse planning. What is the disadvantage of IPSA? I'll start with the bad things and then we'll go to the good things. So what is the problem if you do a interstitial brachytherapy implant after contouring the dose prescription or optimization with IPSA? What is the problem? What is the advantage of ICRT applicator?
So the pear shaped isoversed distribution will be there, sir.
And the pear is concentrated on the uterus cervix.
Yeah, the
Okay.
pear shape.
So here in IPSA, the pear shape distribution is not there. You should be very careful before approving a plan in IPSA. So first of all, what we do here is we contour the thing, we give a pointed distribution, activate the needles when required. Okay, so that can only be possible with a hybrid form of applicators. That is not possible with a Mpro type of brachytherapy. Fine. That's why the hybrid applicators came into existence for the disadvantage of the liquid. Okay, fine. I'll not go into the details. We have limited time, but one more thing I want to specify is how much should be the peripheral needle loading, or how much should be the applicator tandem and ovoid applicator loading, and what amount of radiation should loading should be there from the needles if you are doing a hybrid implant. Anyone can answer this.
Majority should be there from the tandem and ovoid.
So if you are piercing any mucosa, which the applicator, it is a central tandem and the ovoid applicators are not doing, tandem is not doing, then you should be majority of the distribution should come from the ICRT application. Okay, 85%. You should try not to cross 15% distribution from the needles, because these needles are in the interstitium. The normal tissues also are there. We have lot of vessels. We have fatty tissues. We have ureter out there. We have so many things out there. So if the doses is increased out there, whatever the dwell times and dwell positions are increased, the amount of fibrosis happens is extreme in such patients. So ideally 15% of the loading or the dwell time should be from the needles, and rest of the things should be from the
Tandem and
And
ovoids.
tandem and
ovoids.
ovoids. Okay, fine. So coming to last, we'll discuss something about extended field radiotherapy. Okay, so that is not the localized form of pelvic radiotherapy. So what is extended field radiotherapy?
In extended field radiotherapy is given in carcinoma cervix if there is a gross parietic nodes are present. So the margin will be the superior margin will be increased either to T12 region or for the renal veins crossing, or 3 centimeter from the above the gross palpable the topmost nodes.
It's not palpable.
Visible nodes.
So whatever visible in the CT scan, you should go
3
3
centimeter.
centimeter above, and ideally it should minimum be at the level of L2 where the renal veins bifurcation is there. Okay, and beyond that, if there is a node, you should go again another 3 centimeters. Ideally, it will never cross beyond T12, T11. Okay, so there is an extended field radiation. Is it ever given prophylactically?
No, periodic nodes are not given prophylactically.
Why not?
So toxicity is more raised with the periodic radiation. Also, there is no survival benefit with periodic radiation, prophylactic periodic radiation.
So we are adding only the toxicity. We are not giving any benefit in the survival and PFS. Okay. So a node which is not present in the periodic region during the course of EBRT is unlikely to come up in future, because cervix has a long
This is 10 years. It will take from the
latent period of cervix is very long. So 8 to 10 years, 15 years, sometimes more than that. So that time is sufficient for a periodic node to develop. What is the natural history of the disease is. Okay, fine. So that one should be the thing. So if a periodic node is there, suppose a 8 by 6 centimeter node is there in the periodic, maybe in the L2 region, single node with the CS cervix confirmed pelvic nodes are there. So what are the options available to me? So I'm telling you 8 by 6 centimeter node in the periodic.
So initially we can.
What are the options possible to go?
So for periodic nodes only we can go for plucking of the nodes.
So yeah, so ideally two surgery and radiation both in a stage of 3C2 is not advisable. But if a node is very big and if you are supposed to give radiation to that node, the toxicity to the surrounding tissues, that is the small intestine, duodenum, is likely to be much higher. In such case,
you can go for surgery, plucking of
maybe very keyhole surgery type can be done and the node can be plucked out. And no periodic dissection should be done, but okay, and a clip should be placed at that point. So with that, we can identify the area of the node which was present and give radiation to it. Okay. So I'll not go into further details. Madam, any question answers are there?
Someone is asking about NSCT, patient is presenting periodic nodes.
So what is the evidence of NSCT in current scenarios?
Interlaced trial, they are saying so 2 cycles of Brachytherapy, 2 cycles of Brachytherapy can be given. Then that how 8% benefit in PFS.
So yeah,
and that is.
So anything if you go to the critical analysis of interlaced trial, what things you want to add?
Yes, so the age of the patient is most of the patients are in 40 years, and less in the Indian population was not included much. Also, stage 3C1, stage 3C was not involved in those cases. Also, the HRCTV doses, most of the doses didn't get up to 80. The prescribed 85 day was in the.
So the main thing is they have done a 3D plan, and most of the brachytherapy were suboptimal brachytherapy. So suppose you are not doing an image guided brachytherapy, then you can go ahead with the NSCT in such cases. Also, they didn't include very bulky diseases. I think 3A cases was totally avoided in such scenarios. So it's not for, it's for bad risk patient. Majority of the patients bad risk, that is 3A and others, were excluded from the trial. So for our scenarios, we are not following the interlace at present. But if anyone wants to follow it, if you are not doing 3D image guided brachytherapy or brachytherapy is substantial, if you think so, then you can go ahead with 2 cycles of NSCT and rest can be done with the as part of the protocol. The next question is
why IPSA planning is bad?
IPSA planning is not bad. IPSA planning is very good, but it needs you to understand the properly what IPSA is trying to do. So whenever you are trying to plan with IPSA only sees the CTV as the ultimate. It will not consider the uterus and endometrium into existence. Okay. And we know the uterus and endometrium is very important in an ICRT distribution. So because it is almost having 80-90 years of 70 years of history. So first of all, place the ICRT distribution and add on needles. IPSA ideally is not good for this scenario because the central tandem is almost always not activated.
What are the volumes for nodal boosts and how we are giving nodal boosts?
So if you follow the Jack-Istro for the nodal boost, the volumes are strictly maintained. If you are doing a good IGRT, even 0 millimeter margin for the CTV only boost to the GTV and along with that PTV of 3 millimeter can be done. As per our center, we are giving drawing the GTV of the nodes and giving a 3 millimeter margin and additional 5 millimeter PTV because we think because the doctors can not be present daily in the machine to check the patient during setup. And we usually do daily IGRT CVCTs for such patients, but it is majority of the matchings are done by our technologist. So we think that goes with our scenario. But if you are strict and if you are able to check the patients daily in machine, then please go ahead with the minimal margin also.
What should be the size of the node for which we will consider giving boosts?
Mhm.
What is the size of the node?
So there are many indications as I told. If you have a PET CT, please do a PET CT before finding out the node is positive or negative. There is no way of doing a pathological staging until unless you are going for an open oral laparoscopic lymph node plucking. So if the minimum size of the node should be centimeter, it should be round, it should be it should have a multiple maybe central loss of ecogenicity should be there, or irregular margins can be there, or conglomerate nodes. Many nodes, small nodes can also be indicative of the positivity for these nodes. So such nodes we take up for treatment irrespective of their sizes if it is less than 1 centimeter.
Sir, disease involving lower third of cervix without involvement of inguinal nodes. Should we give prophylactic CAR-T to the inguinal nodes?
Technically, anatomically, always it is better to give a lymphatic drainage. So prophylactic node to the inguinal is always advisable.
Sir, is bulky common iliac nodes an indication for prophylactic extended field radiotherapy?
Bulky
Common iliac nodes.
common iliac nodes 2 and more in the region, maybe in the pelvis or in the common iliac, you can extend your upper border up to L2 as per the Jack-Istro, Embrace guidelines. What is the dose schedule? Donna, can you tell us the dose schedules for Embrace?
Sir, Embrace pelvis, they have given 45 gray in 25 fractions. This SIV nodes, the pelvic nodes were boosted up to 55 gray, and the paralytic nodes were
Pelvic nodes that are close
to the
supposed to get radiation from the ICRT are boosted.
were boosted up to 55 gray, and the other nodes, which is away from the ICRT pelvic node, away from the ICRT field, and also paralytic nodes were boosted up to 57.5 gray.
57.5, round figure 58, you can go ahead with 25 fractions. It is an easy procedure, but be careful of giving this dose when the nodes are very close to the duodenum, because we have seen few patients comes with hematemesis and melena after getting such high dose in the duodenal region, because inadvertently the duodenal part, the muscular layer will get radiation from that, and that can have some duodenal ulcers in future.
So does IRCTV nodes needs a dose prescription or just HRCTV is sufficient?
Nowadays, it is told to get at least minimum of 60 gray. So beyond that, studies are going on. Once the reports are out, you will be able to know. But 60 gray is the minimum prescription you could choose. 2 IRCTV. Total dose, that is including the EBRT plus brachytherapy, and if you see the DBH in brachytherapy is the D90 you have to see, so that it gets total dose of 60.
I was asking about the parametrium examination, sir. How to confirm parametrium that is involving up to pelvic side wall?
We have already told. Yeah. Next.
Sir, difference between Peters criteria and Sedley's criteria.
So these criteria will check for post-op cervix if radiation to be given, post-op EBRT should be given or not. It will be based upon stroma invasion, tumor size, and LDSI positivity. So there are four criteria are there in Cervix. If LBSA is positive, deeper stromal invasion and to any tumor size, we have to take the patient for EBRT. LBSA positive, middle third is involved, and the size of tumors should be more than 2 centimeter. We can take for EBRT. LBSA positive, if superficial involvement is there, the size should be minimum of more than equal to 5 centimeter. If no LBSA or a deep or middle stromal invasion is there, the lesion should be at least more than equal to 4 centimeter. These are indications of EBRT. For Peters criteria, it can say about when CT chemo should be added with the with EBRT. So it is positive parameter, positive notes, and positive margins. These three, any one of these three are present, we have to give CTRT for the patient.
So remember, it is always not good to give two modalities of treatment. Maybe surgery and radiation and chemo is not ideal for these patients. Either of the modality is a good option because the side effects are extreme if you combine all the modality of surgery, chemotherapy, and radiation. The toxicity becomes extreme. So, as per the guidelines, if the size is more than 4 centimeters for cervix, we should not attempt any surgery at all. They should be conveyed to all the gynecologists available or the surgical oncologist available in your clinics or hospital. For
total HRCTV.
HRCTV, ideally it should get a minimum of 85 gray. You can push the dose up to 5 gray extra, provided on the last fraction you are finding gross residual disease in the cervix. So we usually do not see much for because cervix, if you see, the uterus can tolerate very high doses up to 160, 170 gray. As you come down, it goes to 90, then upper third of the vagina and the lower third maybe 60 gray. But cervix doesn't create a problem if you are giving a high dose. So only the OR. If the ORs are within the limits, you can try to hit the cervix with 90 gray minimum the doses, provided there is still left residual GTV at the last insertion.
Neoadjuvant chemotherapy versus proton for para-aortic lymph node involvement.
Para-aortic lymph node, please. Neoadjuvant radiotherapy versus proton.
NSCT versus proton.
Okay, so if you are going to follow the protocol of neoadjuvant CT, you should be very careful of finishing the dose as soon as possible, because the longer time you give, it is detrimental for the tumor. So it should be still done on the trial basis if you want to follow the interlaced trial data. But personally, I do not recommend such things till now, till our Indian data are available. Cervix is a disease for low and medium socioeconomic country like India and other Africa. So until unless good data comes from our society, we should not be going into NSCT. That is my opinion, because we can not have a control over medical oncology and the timing of radiation and chemotherapy. And NSCT for these patients. We should not delay the giving the main radiochemotherapy to this patient.
So any evidence for prophylactic RT for inguinal nodality in lower vaginal involvement? Prophylactic.
Prophylactic data are not there, but we can tell you it is the anatomical